Hi there guys, it's me again, John, and thank you for joining me. For this clip, we will do some drills, okay? So this is actually made possible in cooperation with Nurses Hub Review and Training Center and INAP as well. That's your International Nurses Academy of the Philippines. So we have about 10 questions here. So I will read the questions and options as well, and I give you time to answer the question. And don't worry, the questions are not that very difficult, but shall I say moderately difficult, okay? So let's try to answer question number 1. Which of the following diagnosis is most appropriate for a client with hypocalcemia? 1. Okay, constipation, bowel. 2. High risk for injury, bleeding. 3. Airway clearance ineffective. 4. Alteration in comfort, pain. Okay, go back to the question. Which of the following diagnosis is most appropriate for a patient with hypocalcemia? Remember this always. If you would encounter most appropriate, do not forget that it could be all options are correct, or 2 or more options are correct, okay? But you have to choose the best answer, okay? So the question is something to do with the decreased calcium in the blood or hypocalcemia. The normal calcium level in the blood ranges from 8.5 to 10.5 milligrams per deciliter. So you may have a different value in your mind, maybe because you're not using milligrams per deciliter unit, so you may be using a different unit, okay? And even in the hospital, if you jump from one hospital to another, they use different parameters, okay? Now, when you say calcium, calcium is an electrolyte that has something to do with blood clot formation, okay? Therefore, a decrease in the calcium may cause bleeding. So number 2 is a possible answer. So you have to say number 2. Calcium is also important for bone formation, bone growth, bone healing as well. Calcium is also important for muscle contraction and impulse transmission. Having said that calcium is important for impulse transmission, the thing you need to remember here is that the relationship of calcium and impulse transmission. Calcium and impulse transmission, they are actually what? Inversely proportional. In short, if the calcium is high, okay, if you have hypercalcemia, if the calcium is high, impulse transmission is low. If you have hypocalcemia, a decreased calcium in the blood, the impulse transmission will be increased. Therefore, if you have hypercalcemia, increased calcium, impulse transmission is decreased, resulting to decreased peristalsis. Decreased peristalsis will result to constipation or even lead to paralytic ileus and constipation, right? Therefore, your constipation here is not common for hypocalcemia, but instead common for patient with hypercalcemia, okay? Next, calcium has something to do with blood formation. So I said 2 is a possible answer, but I did not say that 2 is the correct one. Calcium is important for, impulse transmission, right? I said that in number 1, the relationship is inversely proportional. If you have increased calcium, I said decreased impulse transmission. A decrease in the calcium will increase impulse transmission, right? So an increase in the impulse transmission will affect the bronchial muscle, the smooth muscles in the bronchial area. So an increase in the impulse transmission will lead to bronchospasm. And bronchospasm can cause airway obstruction. Therefore, will that result to ineffective airway clearance? Yes, it will. Therefore, 3 is also a possible answer. Okay, so we eliminated 1. 2 and 3 will stay there. 4, alteration in comfort, pain. Will there be pain in your hypocalcemia? Most probably no. It's more on for patient with hypercalcemia, increased calcium, because maybe associated with bone demineralization, giving you bone pain, right? But anyway, so we eliminated 1. Let's say we keep 2, 3, and 4. Now, since it's a question about most appropriate, it is something to do with prioritization, right? If you be asked in any type of qualifying examination about prioritization, we may follow the ABC protocol, or we may follow the Maslow's hierarchy of need. If you can still remember your Maslow's hierarchy of need, the lowest part, the bottom area, has something to do with physiologic need. Example for physiologic need: air, water, those are physiologic needs, right? The second layer is psychologic, okay? So the lowest part is physiologic. The second layer is the psychologic. Again, the lowest layer is physiologic. The second layer is your psychologic. Pain is not physiologic. Pain is psychologic need. Therefore, pain is not the first priority. Okay? So we eliminate number 4 just in case, okay, you kept number 4 in the options. Okay? Now, in your ABC protocol, airway, breathing, circulation, we know A stands for airway, so we know that the correct answer here is number 3, right? Because I said hypocalcemia will increase the impulse transmission causing bronchospasm, and bronchospasm can result to airway obstruction. So the correct answer in this question number 1 is number 3. Let's proceed to question number 2. Danny is receiving furosemide and digoxin. Which laboratory data would be the most important to assess in planning the care for the client? First is your sodium level, 2 is magnesium level, 3 is your potassium level, and 4 is your calcium level. Okay? The normal sodium level ranges from 135 to 145. Okay? Magnesium level is 1.8 to 2.7. Other book 1.5 to 2.5 milligrams per deciliter. Potassium is 3.5 to 5.0. Other book 3.5 to 5.5 milli equivalent per liter. The normal calcium, I said that it's 8.5 to 10.5. Okay? Now, the question is something to do with your pharmacology concept. Your furosemide and digoxin. Furosemide, Lasix, it's a form of diuretic. It's a water pill, right? So if you take this furosemide, you will pee a lot. That will increase your, of course, urination, right? But remember, when you talk about diuretics are categorized into 2. Whether it is a form of a potassium-sparing diuretic or a potassium-wasting diuretic. So what's the difference? When you say potassium-wasting diuretic, it's a diuretic, you will pee a lot. Potassium-wasting, you pee a lot, and it promotes potassium loss. Okay? So when you say potassium-wasting diuretics, a good example of this type of diuretics are the following. You have your furosemide, you have your hydrochlorothiazide, or your HCTZ, and last is your mannitol. So furosemide, hydrochlorothiazide, and mannitol are examples of a potassium-wasting diuretic. So if you take this water pill, you will pee a lot and it eliminates potassium. The second classification of your diuretic is a potassium-sparing diuretic. Still, it is a diuretic, it's just that it will not promote potassium elimination. It conserves potassium in the body. So examples of your potassium-sparing diuretics are your spironolactone or your aldactone. We also have your amiloride, and we also have your triamterene. So these 3 are good examples of your potassium-sparing. Okay? Now, when you say digoxin is a form of a cardiac glycoside. Okay? This is the drug of choice for patient having congestive heart failure. If you can still remember in your cardiac concept, okay, congestive heart failure refers to inability on the heart to pump well. So there is no problem with the heart rate of your patient with heart failure. So take note, there is no problem with the heart rate. The main concern or issue of patient with heart failure is the pumping mechanism. So if you give digoxin, or your lanoxin is a form of cardiac glycoside, this type of drug is considered to be digitalis, okay? And this drug has 2 common effects, okay? What are the 2 common effects of your digoxin? Your digoxin has a positive inotropic and a negative chronotropic. So when you say this drug has a positive inotropic, the implication there is that this drug increases the force of contraction, okay? So it increases the force of contraction. Since digoxin has a second effect, which is negative chronotropic, okay? If it has a negative chronotropic effect, it decreases the heart rate of the patient. It may also decrease the blood pressure. So again, digoxin is positive inotropic, negative chronotropic. Having said that, we cannot give digoxin to a patient, okay, an adult patient with a heart rate of less than 60, okay? We cannot give digoxin, okay, for children with a heart rate of less than 100. And we cannot give digoxin to a patient with a blood pressure of equal or less than 90/60 millimeters mercury. Now, another thing to remember with your digoxin is that your digoxin toxicity or digitalis toxicity. Digoxin toxicity is very common to patients with hypocalcemia or a decrease in your potassium. So you know the answer there is number 3, potassium level. Why? If your potassium level is so low, okay, if you have hypokalemia, a decrease in the potassium potentiates the effect of your digoxin. In short, a decrease in the potassium will increase the effect of digoxin, increasing the likelihood of the person taking that drug, okay, to develop digitalis toxicity. Okay, so that's your answer in number 2. The correct answer there is potassium level. So don't forget, watch out for digitalis toxicity. Okay, and if your patient takes digoxin, okay, monitor potassium. Okay, when do we monitor sodium? If your patient takes lithium drug. So don't forget this. The partner electrolyte of digoxin is potassium. The partner electrolyte of lithium is sodium. Okay, so there must be consistent level of sodium as well. Okay, same with your digoxin here. Okay, watch out for potassium, low potassium level in the blood. Okay, for question number 3, you're assigned to a newly admitted patient with fluid volume excess secondary to congestive heart failure. The following are conditions related to the diagnosis. Select all that apply. So this is one of the most feared test format. If you're planning to take the NCLEX here, select all that apply. Remember, the format now is that, the plan now is that in your select all that apply, the minimum answer is 1 option. The maximum answer, all options. Okay? So patient is having fluid volume excess. In short, there is what they call congestion. So what is fluid volume excess? Fluid volume excess refers to an increase in your extravascular fluid. Okay, increase in your extravascular fluid. So you try to analyze if there's increased fluid volume, will there be hypertension? Yes, there will be hypertension. Okay, CVP of 13 centimeters water. The problem there is you don't know the normal value, right? But it's what, just a heads up, if you're planning to take any qualifying exam, you need to memorize the values. Okay, familiarize the values and know the implications. If it's high, if it's low, what is the implication? You need to correlate those, okay, with the different diseases or disease processes. Okay, so CVP is 13. Let's start. What is the normal CVP? The normal CVP ranges from 2 to 8 centimeters water. Again, 2 to 8 centimeters water. So you know a result of 13 is high. What is the implication? An increase in the CVP would mean hypervolemia, an increase in the blood volume. An increase in the blood volume may be related to congestion. So you know that 2 is a possible answer, right? A decrease in the CVP would mean hypovolemia. A decrease in the blood volume may be because of bleeding. Hypovolemic shock, that will decrease your CVP. By the way, when you say CVP or central venous pressure, is a good parameter, okay, to evaluate right side of the heart. Okay, what about the left side of the heart? The left side of the heart is greatly evaluated if you use pulmonary capillary wedge pressure. So don't forget this. Your CVP will evaluate right side of the heart functioning. Your PCWP or your pulmonary capillary wedge pressure will evaluate the left side of the heart. Okay. Hemoconcentration in the blood is concentrated. I don't think so. Remember, if you have fluid congestion, that means to say that the blood is diluted. So instead of having hemoconcentration, it should have been hemodilution. Am I right? So you have to eliminate number 3. By the way, how will you know that the blood is concentrated? By what test? Hematocrit. Remember, if there is an increase, high hematocrit, there is hemoconcentration. A decrease in the hematocrit, okay, would mean hemodilution. Okay, so your hematocrit will tell you how concentrated, how diluted your blood is. That's for your blood. That's different for your urine. If you want to know whether the urine is concentrated or diluted, you need to use the urine specific gravity. Okay, next, weight gain of 1 pound over 24 hours. Highlight in your examination. If you have to read the options, you have to read the entire statement, the entire option. Common mistake of nurses, okay, they read weight gain, they pick the option immediately, but they fail to appreciate the parameter. When can you say that there is fluid volume excess? We can say that there's fluid volume excess if the patient gained, okay, more than 2.2 pounds or more than 1 kilogram per day. Again, if you gain more than or equal to 2.2 pounds, it's only 1 pound. So it will not fall under fluid volume excess. So you have to eliminate number 4. Okay? Tachycardia, increased heart rate, of course, because of congestion. And because of congestion, when the heart rate is increased, okay, the workload of the heart increases as well. An increase in the workload of the heart can cause compensatory mechanism called hypertrophy, and that can be generically or termed as cardiomegaly, enlargement of the heart. Okay, so in your question number 3, your option should have been 1, 2, 5, and 6. Okay, I hope you're able to get it correctly. Let's proceed to question number 4. The nurse would anticipate which of the following arterial blood gas results in a client experiencing prolonged severe asthma attack. Okay, 1 is low partial carbon dioxide pressure, high partial oxygen pressure, low pH. 2, a high partial carbon dioxide pressure, low partial oxygen pressure, and a low pH. 3, a high partial carbon dioxide pressure, high partial oxygen pressure, and a high pH. 4, low partial carbon dioxide pressure, low partial oxygen pressure, and a high pH. Go back to the question. Arterial blood gas analysis, or ABG. This is an important test to evaluate how good is oxygenation, right? So this is a test wherein you need to get blood from the patient in an arterial line, okay? Just remember that before blood extraction for ABG analysis, okay, the technician, maybe a phlebotomist or a nurse, okay, or a respiratory therapist, needs to perform Allen's test. Okay, do not forget this. Your Allen's test is a test that will evaluate collateral circulation of the blood vessel. So you may have here the radial artery and the ulnar artery. You also have the brachial artery to get specimen for ABG. You can also have the arterial line in the lower extremities as well. But among the sites there, the least favorable, okay, not favorable site for blood extraction for ABG is the femoral artery, because again, we cannot check collateral circulation. We cannot do Allen's test, okay, using your femoral line. Okay, so if you will have a prolonged severe asthma, in asthma it's a form of a respiratory problem that will eventually cause airway obstruction, right? So if the airway of the patient is obstructed, perfusion, gastric perfusion is also, the entry of air, okay, into the pulmonary area is affected. So that will result to impaired gas exchange eventually, right? Now, because of that, the patient cannot breathe out oxygen. Cannot breathe out carbon dioxide, okay? Cannot breathe out carbon dioxide. So if you cannot breathe out carbon dioxide, expect that carbon dioxide in the body increases. And what do you call that increased carbon dioxide in the body? You call that your hypercapnia. So you have to look, okay, in the options that there's increased carbon dioxide. Okay, so you have 2 and number 3. So you have to eliminate 1 and 4. Now, since it's a form, the asthma here can cause airway obstruction. Okay, the patient cannot breathe in sufficient oxygen. So apart from having hypercapnia, increased carbon dioxide, patient will also end up having hypoxemia, right? A decreased oxygen in the blood. So what could that be? A low oxygen. And remember, okay, if there's too much carbon dioxide in the body, the relationship of carbon dioxide and pH, these two are inversely proportional. When the carbon dioxide is high, the pH falls. So that will result to acidosis. So a patient with severe asthma will end up having respiratory acidosis and hypoxemia. And what option is that? That is option number 2. So the correct answer here is number 2. Okay? Next, question number 5. The nurse explains to the parents of a 1-year-old child admitted to the hospital in a sickle cell crisis that the local tissue damage the child has on admission is caused by which of the following? So this is a question that has something to do with sickle cell problem. Okay? So something to do with sickle cell problem that resulted to tissue damage. So the question here is asking you, what causes tissue injury in sickle cell problem? Okay? What causes tissue injury or tissue damage? First, autoimmune reaction complicated by hypoxia. 2, lack of oxygen in the red blood cells. 3, obstruction to the circulation. 4, elevated serum bilirubin concentration. Okay, now remember, sickle cell is not a form of an autoimmune problem. Okay, it's a genetic problem, okay, wherein the red blood cell of the patient has a defective hemoglobin S, okay, S for sickling. So what happens there is that if you have sickle cell and you expose the patient in a low oxygen environment, that will result to hypoxia. That hypoxia triggers the RBC to form abnormal shape called sickling of RBC, okay? So hypoxia triggers sickling, okay? And that sickling, okay, that sickling abnormal shape of RBC will eventually cause circulatory obstruction. Now, if there is circulatory obstruction, you now call that as your or vaso-occlusive crisis, or some will call that as your sickle cell crisis. So if there's circulatory obstruction, blood flow is not possible. That will result to tissue injury or tissue damage. Remember, the question in number 5 is asking you what causes injury to the tissue. The answer should have been obstruction in circulation. Correct answer there is number 3. Now, having said sickle cell problem, don't forget this in your examination. If your patient has sickle cell disease or sickle cell problem, the first priority here is actually to what? Either hydrate the patient or give oxygen. The correct answer there is you hydrate the patient. Don't forget that. Hydrate first, and then after you hydrate, you have to give oxygen supplement. Why? It is useless for us to give oxygen to a patient with sickle cell, okay, if the blood is concentrated, because there is poor oxygen adhesion to a blood that is viscous, to a blood that is concentrated. So what will you do there is you dilute it out first, you hydrate the patient, then after that, you give oxygen, okay? So things to remember in your sickle cell problem: hydrate first, then oxygen. Because if you give oxygen and the blood is viscous, the blood is concentrated, there's poor oxygen adhesion. Okay? Next, let's proceed to question number. And by the way, with your sickle cell, tell your patient to avoid high altitude places, because a high altitude area has a low oxygen concentration. Okay? Number 6. The nurse is positioning the female client with increased intracranial pressure. Which of the following positions would the nurse avoid? Okay, so this is something to do with increased ICP, right? So by the way, the normal intracranial pressure is less than 15 millimeters mercury. Okay, so which of the following positions would the nurse avoid? If you have increased ICP, make it sure that the head of the bed of the patient is elevated, right? So head midline, correct. Head neutral, that's your midline, that's number 3, that's correct. Head of the bed elevated, correct. Now things to remember. A patient with increased intracranial pressure, you need to elevate the head of the bed. Not literally that you have to elevate the head of the patient. Instead, what we do to elevate the head is to elevate the head of the bed, not the head of your patient, okay? Now, there are 3 common factors, okay? There are 3 common factors that will affect or influence intracranial pressure. First is your CSF or cerebrospinal fluid, okay? If there's an increase in the CSF, that will also increase ICP. The normal CSF volume ranges from 100 to 150 ml, okay? So if you have hydrocephalus, if there's increased fluid, okay, that will also increase ICP of your patient. So that's the first factor, your CSF. The second factor that will affect your intracranial pressure is the blood volume in the brain, okay? The normal blood volume in the brain is about 150 ml. So if you have brain injury that results to hemorrhage, subdural bleeding, cerebral bleeding, so that will also increase intracranial pressure of your patient, okay? And the third factor that will affect ICP is the brain mass, okay? The brain itself. So if you have brain tumor, in short, there's a new tissue that grows, there's a new growth, an increase in the brain mass, okay? By the way, the normal brain mass is about 1,200 ml. So there's an increase in the brain mass, example, brain tumor, that will also increase the ICP of your patient. What's good about these 3 factors is that they help one another. If one factor is high, the other factors will decrease, okay? Just to maintain okay, a normal pressure in the intracranial area. You call that process as what we call Monro-Kelly doctrine or Monro-Kelly hypothesis. It means to say that an increase in one element is compensated by other element, okay? Now, a patient with increased ICP, I said you have to elevate the head of the bed. Make it sure that when you elevate the head of the bed, the head of the patient must be center, midline, or neutral position. Do not allow the head of the patient to face on the sides. Why? Facing on the sides will lead to compression of the blood vessels on the sides of the neck. Compressing the blood vessels on the sides of the neck will impede venous return or venous flow. As a result, the blood will congest in the upper part, increasing ICP of your patient. So don't forget, a patient with increased ICP, head of the bed elevated, head of the patient must be center or neutral position or midline, okay? And don't forget that you have to provide measures that will decrease ICP of your patient. And what are those? You may give laxative, you may give osmotic diuretic, you have to avoid constipation, avoid vomiting, avoid Valsalva, avoid bending body below the waist, avoid lifting, am I right? Avoid moving head too rapidly. So those are parameters that will decrease intracranial pressure of your patient. And having said that there's increased ICP, it is also important for a patient on the first 24 hours with increased ICP to induce hyperventilation. Why? Why is hyperventilation important and helpful for a patient with increased ICP? Remember, if the patient hyperventilates, please bear with my hair, and I went to the salon a few hours ago, but just so happened they're closed because of the COVID-19 crisis that we're facing right now. So anyway, so let's go back. I said, if the patient hyperventilates, okay, that will promote carbon dioxide loss, right? So when you lose carbon dioxide, that will decrease carbon dioxide in the body, okay? So a decrease in the carbon dioxide in the body is called hypocapnia, okay? So what is the effect? When carbon dioxide in the body decreases, the peripheral vessels will constrict, okay? The cerebral vessels will constrict. The pulmonary vessels will dilate. Again, if there is a decreased carbon dioxide in the body, the blood vessels in the peripheral area will constrict. The blood vessels in the brain will constrict, but the blood vessels in the lungs will dilate. Okay? So what is the implication? When the blood vessels in the brain constrict, decrease blood flow to the brain. Decrease blood circulation to your brain because the blood vessels constrict. So a decrease in the blood flow will decrease blood volume in the brain. Remember the three factors that will affect ICP: CSF volume, blood volume in the brain, and the brain mass. Am I right? So a decrease in the blood volume in the brain will also decrease ICP of your patient. Okay? But that must be done on the first 24 hours. Okay? Next. By the way, the correct answer in number 6, you need to avoid turning patient head turn to side. We only do that, okay, by the way, we only do that turning the head of the patient on the side if you don't want the patient to aspirate, okay? So it's for your aspiration precaution. Next, number 7, identify the tracing. What do you think is this ECG tracing? Okay, so let's identify the waves. So this is your P wave, QRS complex, T wave, PQRST. Questions, are waves complete? Yes, the waves are complete. Okay, now what about rhythm? Do they have rhythm? Yes, they have rhythm. They have the same R to R interval. Am I right? They have the same R to R interval. Now, how will you know and how will you read, okay, how will you read the heart rate of your patient here? Normal, okay, the waves are complete, the rhythm normal, regular rhythm. I hope you can still remember, or you watched my videos before about reading the heart rate of the patient in the ECG. Remember the 6 numbers, the 300, the 150, 100, 75, 60, 50. How will you do that? Look for an R wave. These are your R waves, right? Look for an R wave that falls directly on a dark line. This is a dark line, dark line, dark line. So look for an R wave that falls directly on a dark line. So this is an R wave that falls directly on a dark line. The next dark line, you start counting 300, then okay, 150, 100, 75, 60, 50. Now look, R wave that falls directly is a dark line. The next dark line is 300. Okay, 300, 150, 100, 75, 60, 50. That's how you count it, okay? 300, 150, 100, 75, 60, 50. Let's go back. Look for an R wave that falls directly on a dark line. then look for the next R wave. This is the next R wave, okay? This is the next R wave after this. So look, R wave that falls directly on the dark line. Next dark line, you start counting. 300, 150, 100. 100, 150. The next R wave after this, the next R wave falls between 100 to 150, close to 150. What is the heart rate of your patient? 100 to 150 beats per minute, okay? If this R wave falls directly here in this dark line, then the heart rate is exact 150 beats per minute, okay? We know for the fact that the normal heart rate ranges from 60 to 100. If your heart rate is more than 100, that's tachycardia, right? But remember, question here is identify the tracing. So we have a NOK, the PUK, all waves are complete. You have the P, Q, R, S, T, am I right? Waves are complete. PR interval is normal. PR interval is normal, okay? Okay, rhythm, okay, they have a regular rhythm. It's just that the heart rate of the patient is more than 100. So what tracing is this? This is what we call sinus tachycardia. So if a patient is having sinus tachycardia, what is the usual management? How do we treat patient with this type of condition? Well, a patient with sinus tachycardia, we give beta blockers, right? Or if not, we can give calcium channel blockers. Or if not, there is such thing as what we call carotid massage. So you carotid massage, okay, that is done in order to stimulate the vagus nerve. Remember, once the vagus nerve is stimulated, it can cause decreased heart rate, okay? So this is what we call your sinus tachycardia, okay? What about for patient with sinus bradycardia? What drug of choice? What drug will be given to your patient? Of course, your atropine. So atropine is given to patient with sinus bradycardia. Your atropine will increase the heart rate. But for patient with sinus tachycardia, we give beta blockers, we give calcium channel blockers, okay? We also give anxiolytic if the patient is anxious. Remember, anxiety can cause sympathetic response and that can cause tachycardia, okay? We also do carotid massage. Okay, let's proceed to question number 8. Hey. Identify the tracing. Now it's moving. It's a video clip. Okay, one thing for sure, they don't have rhythm, right? The R interval is not regular. Remember, if there is no rhythm, automatically we can label that as fibrillation, right? So this is fibrillation, but there are QRS. So there are QRS, so the problem there will be atrial. Am I right? Because there are QRS complex. The QRS complex will represent the ventricular area. So there are QRS complexes here, so there's no concern, there's no problem with your ventricles. The problem here will be your atrium. So this is what we call atrial fibrillation, okay? So this tracing is atrial fibrillation. So if you have an atrial dysrhythmia, what medications will be given to your patient? We have your PQ meds, right? So what are these PQ meds? PQ meds will be your procainamide and your quinidine. Okay, these are the first-line drugs given to patient with atrial dysrhythmia. Apart from your procainamide and quinidine, we can also give aspirin to patient because any patient with atrial dysrhythmia prone for stroke, prone for a clot, okay? So you have to give aspirin. Aspirin is a form of an antiplatelet drug, okay? So it's an agent that prevents platelet to form a clot, okay? Next, number 9. What are levels of estrogen and progesterone during follicular phase of menstrual cycle? Oh, it's an OB question. What are levels of estrogen and progesterone during follicular phase of menstrual cycle? Okay, so number 1 is low estrogen, low progesterone. 2, high estrogen, high progesterone. 3, high estrogen, low progesterone. 4, low estrogen and high progesterone. Okay, so it's an OB question and has something to do with the menstrual cycle. Now remember, in your OB concept, when you say menstrual cycle, there are 3 phases in your menstrual cycle, but there are also other book, okay, that there are 4 phases, okay, but I only give 3, but I can give you the 4 phases. The first phase is what we call the menstrual phase. After menstrual phase is your follicular phase. After follicular phase is your luteal phase, and after luteal phase, other book We call that as your ischemic phase. Okay, so you have your menstrual phase, follicular phase, luteal phase. Other book, the fourth phase is your ischemic phase. Okay, so the question here is follicular. In follicular phase, expected that there is an increase in the estrogen, decrease in progesterone. Okay, so increase in estrogen, decrease progesterone. The answer should have been number 3. Okay, it should be number 3. So let's identify these 3 phases again. So first phase is your menstrual phase. Your menstrual phase, that is the actual phase wherein you have your mens. Am I right? So in your menstrual phase, the levels of your estrogen and progesterone are low. So again, in menstrual phase, you will have low estrogen, low progesterone. Okay? The second phase is your follicular phase. Okay? Another name of follicular phase is estrogenic phase. Okay? So don't forget this. Estrogenic phase, follicular phase are the same. Okay? Now, what are levels of estrogen and progesterone during follicular phase? So in this phase, I said there will be increased estrogen, decreased progesterone. Okay? Again, increased estrogen, decreased progesterone in your follicular phase or estrogenic phase. That is why we call it estrogenic phase, because the hormone elevated is your estrogen. Okay? The third and the last cycle is your luteal phase. Okay? Luteal phase. Another name of luteal phase is progesteronic phase. So you know that in this phase, the hormone that rises is your progesterone. That is why what are levels of estrogen and progesterone during luteal phase or progesteronic phase? You will have increased estrogen and increased progesterone. Okay? Again, increased estrogen, increased progesterone. Remember, it's a cycle. It's a cycle. So again, menstrual phase, low estrogen, low progesterone. Follicular phase, high estrogen, low progesterone. Luteal phase, high estrogen, high progesterone. Okay? That is question number 9. So number 9, the correct answer there is number 3. Let's proceed to question number 10, and I believe this is the last question. The LPN has just taken the blood pressure of a client who had thyroidectomy. The LPN tells a nurse that the client's hand turned into claw when the blood pressure was taken. Which intervention should the nurse implement first? Again, implement first. What will you do first? Okay? Prepare to administer IV calcium gluconate. Assess the client for signs and symptoms of hypoparathyroidism. Request the UAP to elevate the client's head off the bed. Notify the client's healthcare provider immediately. Okay. LPN took the blood pressure. So when the LPN took the blood pressure, the LPN notices that the hand of the patient turned into claw like this. So if the patient assumes that position, assumes that posture, not posture, but assumes this manifestation or positioning, okay? This is a clear manifestation of what type of sign. You call this sign as your trousseau or trousseau, okay? Some would say trousseau, some would say trousseau, but nevertheless, it's a sign of hypocalcemia. Remember, when doctors perform thyroidectomy, removal of the thyroid, there's a possibility that when the doctors remove the thyroid, accidentally the parathyroid gland is also removed. Okay? So when doctors remove the thyroid and accidentally remove the parathyroid gland, nobody now produces PTH or parathyroid hormone or parathormone. So if there's no more PTH, the calcium in the blood will not increase, causing hypocalcemia. So a decrease in the calcium, again, will give you an idea that patient with or post-thyroidectomy with hypocalcemia may manifest trousseau and may have airway obstruction because of what we call bronchospasm with respect to question number 1, right? Hypocalcemia can cause bronchospasm, which is a priority. But the question there is, who told you that the patient hand turned into claw when he or she took the blood pressure? It's an LPN, right? I don't discredit that LPN or UAP, we work as a team, but take note as a nurse, do not rely with their assessment. Am I right? Do not rely whatever they say. I am not saying that they're incorrect, But as a nurse, it's our responsibility to reassess or assess the patient first. Okay? Even in the monitors in the hospital. Let's say you have your cardiac monitor, you have your pulse oximeter. Okay? In your cardiac monitor, it shows VTAC. In your pulse oximeter, you can see there, oh, the O2 saturation of the patient is 60%. Will you rely on those equipment? No. What will you do? Assess your patient. That is why even if it is an LPN, if it's UAP, when they tell you something, do not tell that I don't believe you. It's just that it is my responsibility as a nurse that I need to reassess or assess my patient. And by the way, LPN are not allowed to what? Assess patient. Okay, remember LPN, UAP, we cannot delegate what we eat. Okay, what are those? We cannot delegate evaluation, we cannot delegate assessment, we cannot delegate teachings or health teachings, right? Therefore, what about, sir, what about vital signs monitoring? It's a form of assessment, yes. But what you said that we cannot delegate assessment, there's a specific parameter there, restriction. You can delegate assessment to them if that is routinary assessment. Example, vital signs monitoring every 4 hours. Am I right? Okay, blood glucose monitoring every 6 hours, right? Or 4 times a day. It's routinary assessment. But if that assessment is a prerequisite before medication, after medication, or before procedure, or after procedure, these are prerequisite assessments. You cannot delegate that to them. Okay, so I just want to make it clear. You can delegate routinary assessment, but you cannot delegate, okay? You cannot delegate prerequisite assessments, okay? I hope I made that clear. So, what do you think is the best answer here? The best answer is to assess for signs and symptoms of hypoparathyroidism, because again, I said post-thyroidectomy, there's a risk of accident removal of the parathyroid gland resulting to hypoparathyroidism, okay? And in hypoparathyroidism, there's hypocalcemia, okay? So that sign is what we call your trousseau or your trousseau. There's another sign. If you tap 2 to 3 centimeters anterior to your earlobe, okay, patient twitches unilaterally, one side of the face, you call that as your Hobstead sign, which is also another sign of your hypocalcemia. But between Hobstead sign and your trousseau or trousseau is more sensitive to hypocalcemia, okay? So those are questions, guys. I hope you learned something. Just give me a thumbs up if you want to have videos like this, okay? And if you have any clarifications of the questions and you don't agree with my answer, okay, please drop a comment on the comment section below, or you can send any private message to me, okay? God bless everybody, keep safe, and hope to see you soon in my next video clip. Bye, guys.